You made it through all of the microcytic, normocytic, and hemolytic anemias. You definitely deserve a pat on the back for that. So, for our last anemia, the macrocytic kind, just sit back and enjoy some over-the-top, taboo-shattering, unabashedly 80s professional women's wrestling. Yeah, this was actually a thing, with teams composed of aspiring actresses, models, and show dancers. Over 500 matches were held between 1986 and 1992, garnering millions of TV viewers. It was kind of a big deal. And on that note, it's time to introduce our last anemia. Also a pretty big deal. It's macrocytic anemia. Clinically, macrocytosis is defined as a mean corpuscular volume greater than 100. The more subjective method just involves checking out the blood smear. If the red blood cell is larger than the nucleus of a nearby lymphocyte, you're looking at macrocytosis, my friend. And no introduction is complete without some spectacular and dangerously close to that insulation, now that I think about it. Megablast pyrotechnics. Macrocytic anemias can be divided into megaloblastic and non-megaloblastic forms, based on the presence or absence of large nucleated RBCs called megaloblasts. In this scene, we're going to focus on the megaloblastic version, because it's just way more exciting. So what causes megaloblastic anemia? Normally, RBC progenitors in the bone marrow progress through several stages, finally becoming a normoblast, ejecting their nucleus, and leaving the bone marrow as a reticulocyte. This normal progression from progenitor to reticulocyte requires synchronized changes in DNA and RNA. When conditions arise that affect the cell's ability to make or alter nucleic acids, things can get seriously, well, just take a look for yourself. It's not good. Having trouble getting that lighter started there, buddy? Throughout this sketch, we're going to be messing with nucleic acid synthesis in various ways, thus interfering with DNA maturation and cellular division. What results is a kind of DNA-RNA asynchrony, where DNA is lagging behind, while RNA translation and protein production in the cytoplasm continue. Over in the audience, behind the bone fence, let's show what this means for the bone marrow. Starting with the developing red blood cell. Because mRNA translation continues, the cytoplasmic region of the cell, containing organelles and proteins, continues to grow. The nuclear region, on the other hand, has some issues. Notice that this cop here is trying, unsuccessfully, to break up a fight, evoking an image of impaired cell division. What you end up with is an expanding cytoplasm around a nucleus that can't divide. And the cell just keeps growing, resulting in a very high MCV. We're talking 110 to 115. In the rare case that a bone marrow aspirate is collected for diagnosis, it will appear hypercellular. Now, this might lead you to believe that these patients don't have anemia. Plenty of cells, right? Well, despite the hypercellularity, many of these abnormal cells rapidly undergo either apoptosis or phagocytosis by macrophages, right there in the marrow. This leaves only a few fully differentiated RBC precursors to be released into the circulation. So there you have it, macrocytosis and anemia. On the CBC, you should also measure an unusually low reticulocyte count. At Sketchy, reticulocytes are represented by a mesh teabag, like this one, because reticulocytes contain that characteristic net-like chromatin, as opposed to mature RBCs, which have no nucleus. Plus, a teabag is like a precursor to a cup of tea. Know what I mean? Anyways, reticulocyte count measures the number of immature RBCs in the circulation, and it's usually elevated in the setting of hemolytic anemia, when the bone marrow ramps up RBC production to compensate for red blood cell loss. When anemia is due to dysfunction of the marrow itself, though, RBC production and retic count lag behind. While we're still in the bone marrow, keep your eyes peeled for the hallmark of megaloblastic anemia: megaloblasts. Ah, do we even have permits for these? A megaloblast is a very large nucleated cell, containing lots of lacy chromatin surrounded by an abundance of basophilic cytoplasm. These erythroid precursors are described as oval or egg-shaped, and can be seen in the bone marrow aspirate sample along with other abnormally large and weird-looking metamyelocytes and megakaryocytes, which are the granulocyte and platelet precursors, respectively. Yup. Every cell line gets messed up when you interfere with DNA synthesis. On the blood smear, you might spot another classic finding: hypersegmented neutrophils. Normally, neutrophils contain nuclei with multiple lobes. However, when you have 5 lobes or more, we consider that hypersegmentation, a tip-off that these cells aren't maturing normally. At Sketchy, neutrophils are represented by first responders. And you see that collapsed fan they're carting off? She's got a pair of multi-lobed pom-poms. Hypersegmented, if you will. All right, it's time to illustrate the 2 main ways we can disrupt DNA synthesis in the bone marrow. Either we get rid of folate or we get rid of B12. Let's start with folate. First, we'll go through the normal folate cycle and its role in purine and thymidine synthesis, and then we'll illustrate what happens when you remove folate from the equation. To do that, let's go step by step through the usual pre-match ritual of a competitor here at the Women's Wrestling League. Step number 1, you gotta get energized with the vitamin-rich leafy green breakfast. Folate is also called vitamin B9, as highlighted on the front of that iceberg lettuce bag. Folate is found in numerous plant and animal products, especially dark green leafy vegetables. So eat up! And that brings us to step 2. The costume you choose for the match is crucial. Let's say your wrestling name is The Exterminator. Do you wear a gas mask, jumpsuit, and fully functional pesticide canister? Yup. Better yet, completely wrap yourself in nothing but sopping wet trash on the bottom, and moderately use sticky flypaper up top. Let's just say that, in this league, I've seen more competitors win on sheer flamboyance alone. As we peruse our options, notice that we've incorporated the folate cycle within the counterclockwise cycling of the costume rack. Dietary folate first gets converted to dihydrofolate, represented by the double leaf pattern. Dihydrofolate turns to tetrahydrofolate via the enzyme dihydrofolate reductase. Think of tetrahydrofolate as a 4-leaf clover. Next, a couple carbon groups are added to tetrahydrofolate. These methyl groups are represented by the addition of a luchador mask with a cool double C design. All right, now that we've powered up tetrahydrofolate with a couple methyls, we're ready to make some nucleic acids. From here, the cycle starts powering either purine synthesis or pyrimidine synthesis. To represent folate heading off into the purine pathway, we have a costume flying off the rack, decorated with a purine-esque molecular pattern. To make pyrimidines, specifically thymidine, the folate cycles back, dropping those methyl groups and turning back to dihydrofolate in the process. And the whole thing starts over. Notice that this time, the costume flying off is emblazoned with a pyrimidine molecular pattern. Overall, rather than memorizing the specific steps, just keep in mind that the folate cycle is powering nucleic acid synthesis. So, what happens in the setting of folate deficiency? Well, nucleic acid synthesis grinds to a halt, which in turn halts DNA production, leading to megaloblastic anemia. It's actually quite rare for individuals in the US and other developed countries to become folate deficient, since folate is abundant in most foods, especially leafy greens. That is, unless all the veggies you eat are cooked, which will degrade folate within minutes. You'll likely consume some other fortified source, however, as many countries now supplement cereal, flour, and grain products with folate. Without these dietary sources, it's possible to deplete your liver stores in just a few months' time. Around the commentator's booth, let's illustrate a few ways this can happen. First up, goat's milk, proud sponsor of the Women's Wrestling League. Got folate? Nope. Goat's milk, unlike cow's milk, does not contain sufficient amounts of folate to maintain normal DNA synthesis. This means that folate deficiency can occur in malnourished infants that are fed only goat's milk. Also, you see that intestinal-looking rope falling from the ring? Once folate is inside the GI tract, it's enzymatically converted to an absorbable form and actively taken up by the duodenum and jejunum. Because the primary site of absorption is the small bowel, processes that decrease the amount of surface area for absorption, such as celiac disease or short gut syndrome, can lead to deficient uptake and megaloblastic anemia. Alcoholics are especially prone to developing folate deficiency, at least in part due to an impairment of folate uptake and storage by the liver. Unlike other causes of folate deficiency, alcohol abuse can lead to megaloblastic anemia in a matter of weeks, since it effectively renders folate stores useless. Another subset of individuals prone to folate deficiency are those who experience chronically high RBC turnover, such as patients with uncontrolled hemolytic anemia. To convey chronic hemolysis, we've combined our usual chronic grandfather clock with a few cracked RBC shapes. In the setting of chronic hemolysis, the bone marrow normally ramps up production of RBC precursors. The ensuing rapid cell division and DNA synthesis can deplete folate stores at a greater rate than dietary influx, leading to an indolent folate deficiency. Because purines are required for cell division in virtually every cell in the body, symptoms are especially pronounced in areas with lots of rapidly dividing cells, such as the mouth and gut. A sore, swollen tongue, aka glossitis, is a common clinical finding in patients with folate deficiency, as well as B12, which we'll see in a moment. And on labs, just remember that our theme here is megaloblastic macrocytic anemia. Folate deficiency leads to a very high MCV, a crowded bone marrow, hypersegmented neutrophils, and the potential for abnormal platelets and leukocytes, as all cell lines in the bone marrow can be affected. Now, there's one final lab value to report: homocysteine. And to see why, let's head back to the folate cycle. Recall that after folate enters the cycle, we've got to power it up with some methyl groups. That carbon-themed luchador mask, remember? Folate uses these carbon groups to make purines and pyrimidines, as we represented earlier with those clothes flying off the rack. The folate cycle is, in essence, your body's way of distributing carbons around. Well, there's an alternate pathway that methylated folate can take that we haven't drawn in yet. And it involves an enzyme called tetrahydrofolate, abbreviated MTHFR. Notice where that tetrahydrofolate is headed. MTHFR takes one carbon, which is why there's just one C left on that luchador mask. And the remaining carbon is donated to homocysteine, turning it into methionine. At Sketchy, we represent homocysteine with a homing beacon. And during today's match, the homing beacon will be worn by our reigning champions.
Orange is the new SmackDown. It's the inmate.
As she dons that mask, let it represent homocysteine turning to methionine, highlighted by the "me is the one" sign held in the back. Also, keep your eye on that 4-leaf tetrahydrofolate jersey as it's cast aside. Folate is recycled and sent back to the cycle. It picks up more methyl groups in the process and starts all over again. And that brings us back to folate deficiency. No folate means no methyl groups available to turn homocysteine to methionine. As a result, homocysteine builds up in the serum. Now, folate isn't working alone here. It's merely a carbon donor. It's time for vitamin B12 to enter the ring. At Sketchy, vitamin B12, also called cobalamin, is symbolized by a cobalt blue firework. B12 is a coenzyme that aids in methyltransferase reactions, including the homocysteine to methionine conversion. So as you can see, a B12 deficiency will present much like a folate deficiency. If homocysteine can't turn to methionine, homocysteine will start to back up in the serum. Not only that, folate is trapped in its methylated form and can't re-enter the folate cycle. And when that folate cycle stops churning, say goodbye to purine and pyrimidine synthesis, resulting in megaloblastic macrocytic anemia. All the same stuff we saw before: an elevated MCV, crowded bone marrow, hypersegmented neutrophils, and the potential for abnormal platelets and leukocytes. Remember, all the cell lines in the bone marrow are affected. With B12, though, it gets even worse. Vitamin B12 is also an important cofactor for methylmalonyl-CoA mutase, the enzyme responsible for turning methylmalonic acid, which comes from fatty acid breakdown, into succinyl-CoA. This is illustrated back up on stage. For the special pre-fight press event, it's time to introduce the opposing team.
Jacks of all trades, masters of a pawn, no holds barred, unless you mean holding a candle to their prowess, which is barred because you can't. I really should write these down. It's the mixed martial artists!
All right, take a close look. The zigzag pants are meant to evoke an image of fatty acid chains. From odd chain fatty acid breakdown, you get methylmalonyl-CoA. That's where MMA comes in. Technically, MMA stands for methylmalonic acid, the form of methylmalonyl-CoA that builds up in the serum when B12 is deficient. But just bear with me for a moment. We'll get into that. Normally, B12 acts as a coenzyme to facilitate the conversion of this methylmalonyl compound to succinyl-CoA, highlighted by the other sign in the back. Sucks. Can't really read that first part. Really just an overall poorly conceived design. But I like the enthusiasm. As you can tell, B12 is one active enzyme. So how does the body keep up with the high demand? Well, the liver normally holds a 1,000-day supply of B12. Yes, you heard that right. So changes in the diet can take literally years to deplete the stores. To remind you of 1,000 days, we've written 1K on the side of the firework. Yup, that's 1 whole kilo of unlicensed and probably not Endora-approved explosive. Unlike folate, vitamin B12 is not denatured by cooking or UV light, and it's present in all animal products, so rest assured, you carnivores. All right, time for the main event, B12 deficiency, illustrated here by the faulty cobalt fireworks on each side of the ring. Let's first take a look at a few of the most common causes. Oh man, it's turning into a clinic out there with a perfectly executed flying vegan. Unlike folate, B12 isn't present in plants, which means that occasionally, deficiency can occur in strict vegans who avoid all animal products and don't take vitamin supplements. B12 deficiency can also occur in chronic alcoholics after years of poor nutrition. You see her in the corner there, just hanging back and spraying the suds? That move is called the now you see me, now you have alcohol on your face. It's an effective tactic. Normal absorption of B12 requires 4 things. 1, an acidic environment in the stomach, which allows activated pepsin to cleave B12 out of food. 2, intrinsic factor to bind and carry B12 into the body. 3, a functional pancreas, oddly enough, which allows intrinsic factor to bind B12 in the small intestine. And lastly, an intact ileum to serve as the site of B12 absorption. It's complex, so let's illustrate a few more pathologies, each inhibiting one of these steps. Oh, snap! We call that move Lemony Snicket's series of unfortunate penetrating abdominal injuries. No one calls it that. Achlorhydria, or a lack of gastric acid production, is represented by those acidic lemons scattered on the mat. No acid means no activated pepsin, and B12 is locked in food. So, patients on long-term gastric acid suppressing medications, such as PPIs and H2 blockers, may develop B12 deficiency. Really, any pathology that gets rid of the functional cells of the stomach, including chronic gastritis or bariatric surgery, can lead to a similar state of achlorhydria. Not only that, no stomach lining also means no intrinsic factor from parietal cells. And that brings us to our next pathology. Uh-oh, looks like we have an audience member in the ring, spouting sexist nonsense. Why don't you take a seat, my friend, with your face? As I'm sure you've deduced, any condition affecting these steps can interfere with B12 absorption and lead to deficiency. See the antibody shape we've incorporated into the chair? This represents pernicious anemia, an autoimmune condition in which autoantibodies bind to intrinsic factor in the stomach, destroying intrinsic factor in the parietal cells that produce it. B12 needs to bind intrinsic factor before it's properly absorbed. So, not good. Interestingly, even though intrinsic factor is made in the stomach, it binds to B12 only after the stomach contents pass into the duodenum. This requires an extra step that involves a more neutral pH where trypsin can cleave B12 from carrier proteins. Wait, trypsin and bicarb are important too? That means we need a functional pancreas. Therefore, B12 deficiency can occur in the setting of pancreatic insufficiency or chronic pancreatic disease. All right, let's say all these previous steps are A-OK, and B12 is finally allowed to bind to intrinsic factor. It still needs to be absorbed. This occurs at the ileum, so any disease affecting the ileum, such as Crohn's disease or surgical resection, can cause a B12 deficiency. Here's a fun one. See how the ropes in the back look a little tapewormy? The tapeworm Diphyllobothrium laudum is transmitted from fish to humans and latches onto the ileum. Once there, it competes for B12, sucking it away before the small intestine can take it up. Check out our sketchy micro sketch on cestodes for more info on this gross wormy thing. So there you have it. We now have all the ingredients to diagnose either a B12 or folate deficiency. First, get a good history and look for those common predisposing conditions that we talked about. Second, get that CBC and blood smear, checking for anemia, macrocytosis, and low retic count. Third, check the serum B12 and folate levels. Yep, they can just be directly measured in the blood. But if you still can't tell, there's a few more molecules you can measure. Keep in mind that cobalt firework all the way to the left. No B12 means you can't turn homocysteine into methionine and methylmalonyl-CoA into SUX. As a result, both homocysteine and methylmalonic acid start to build up in the serum. This is represented by the homing beacon-wearing inmates and the MMA fighters, building up in each side of the ring as they wait their turn. Recall that folate deficiency is associated with an elevated homocysteine only. In B12 deficiency, on the other hand, you'll likely see both MMA and homocysteine elevated. Over on the MMA side, check out our next contestant here, discarding her myelin sheath sweatbands as she prepares to enter the ring. It turns out that B12 is important for myelin synthesis. So in the setting of deficiency, expect some nerve damage. In fact, neuropsychiatric changes can manifest in all kinds of ways, all the way from cognitive impairment, depression, and psychosis to visual and peripheral nerve deficits. One classic presentation results from damage to the nerve tracts inside the dorsal and lateral columns of the spine, a process dubbed subacute combined degeneration. The combined part referring to involvement of both sensory pathways in the dorsal spinal column as well as motor pathways in the lateral pyramidal tracts, columns and pyramids. Sensory symptoms include paresthesias, numbness, and a sensory ataxia, while motor symptoms can include weakness or even full-on paralysis. This is yet another distinguishing factor of B12 deficiency, though some neurological symptoms have been reported in patients with folate deficiency as well. As you can probably imagine, treating a B12 or folate deficiency involves supplementing the missing vitamin. One little thing to watch out for, though. Inappropriately treating a vitamin B12 deficiency with folate supplementation alone can actually make things worse. First of all, this will only correct the anemia and not the neurosymptoms that go along with B12 deficiency. But on top of that, it's been shown to make the neuro problems worse. So when someone offers you a folate-fortified salad, you just kick them in the face and demand the real deal. B12, that is. Oh, and another thing. Disrupted DNA synthesis in areas with lots of rapidly dividing cells, such as the mouth and gut, is associated with B12 deficiency as much as it is folate deficiency. Well, that's it. Time to sum this thing up. When folate or B12 don't show up to the party, the cells can grow, but the DNA can't replicate. These cells may undergo apoptosis or phagocytosis in the marrow, which quickly becomes overcrowded with these non-budding progenitors. Cell division stops, and you're left with a big nucleated cell. Neutrophils can be hit too, often appearing hypersegmented with 5 or more nuclei buds. And since this is a problem of the marrow, there are no reticulocytes to tag in. Folate, B9, is a methyl donor in the form of tetrahydrofolate and is required for purine and pyrimidine synthesis. In addition, methylene tetrahydrofolate reductase is one bad motherfucker.
Shut that mouth.
But I'm talking about MTHFR, which borrows a carbon from folate to convert homocysteine to methionine. Lack of folate shuts this down and leads to accumulation of homocysteine only. Diet, malabsorption syndromes, and chronic hemolytic states can lead to deficiency in months, while alcohol can inhibit use and deplete stores in weeks. Cobalamin, B12, is also involved in methyltransferase reactions throughout the body, including the homocysteine to methionine reaction. Another important one is the conversion of methylmalonyl-CoA, MMA, to succinyl-CoA. Therefore, in B12 deficiency, you have an accumulation of both homocysteine and MMA. B12 also helps reintroduce tetrahydrofolate to the folate cycle. And lack of B12 locks tetrahydrofolate in its methylated form. Luckily, the body has adapted so that it usually takes years to deplete B12. Possibly because it's so hard to absorb. B12 absorption can be inhibited by anything that reduces gastric acidity, intrinsic factor production, or absorption in the ileum. Though it takes years to deplete, if it happens, it's severe, as a lack of B12 inhibits myelin production and causes a myriad of neurological deficits in addition to the megaloblastic anemia.
Get her, girls.
No, wait, you guys don't understand. I'm just here to watch.
No, I always do my makeup like this. Please don't hurt my body.